Okay. Well, hello there, everyone. Welcome again. This is Dr. Leslie Kernisan of Better Health While Aging and the Helping Older Parents membership. And welcome to today's Challenges with Aging Parents Q&A call. I'm really glad to be here. Answering questions is one of my favorite things. And today's session is extra fun for me because instead of answering questions on my own, I'm going to be answering them in tandem with one of my favorite colleagues, Michelle Allen, who is a licensed clinical social worker, and a certified aging life care professional. Michelle, I'll let you say a few words again, introducing yourself, and then we'll keep going.
Hello, everybody. My name's Michelle. I'm a licensed clinical social worker working as a care manager in the Metro Atlanta area, and I've been with helping older parents since 2019.
Yes. And I'm very, very grateful to have your help with the Helping Older Parents membership. Here also with us is another key member of the Helping Older Parents team, Carol Bradley Bursack. She is here in the chat providing some additional support and resources. She is a bona fide elder care expert in her own right. She's the author of Minding Our Elders. She has cared for, I think it's seven family members or other close ones over the course of her life. And we are very lucky to have her as our community moderator for the Helping Older Parents membership. And she also joins sometimes for these calls to help us out as well. So let me briefly explain how these Q&As work. Some of you may have been here for the one that I did in late October. But what we're going to do is Michelle and I are going to be taking questions that you put into the Q&A box. So if you look around on Zoom, hopefully everyone's familiar with Zoom. If not, you can ask in the chat. Carol can help you out. There should be a box somewhere that says Q&A, and you can pop your questions. Anything about caring for an older parent or another older loved one, go ahead, put it in the Q&A box. And then we also have the chat, and I love it when people participate in the chat. Highly recommended. It's a great place to share thoughts, experiences, insights, encouragement for each other. Just not questions from me and Michelle because the chat goes by too quickly for that. And I also recommend making sure your chat settings are set so that the anything you post goes to everyone, not just me and Michelle and Carol, not just host and panelists. And then before we get into questions, I'm also going to say a few words about the Helping Older Parents membership because you've maybe heard me refer to it a few times here. And these free Q&As that I'm doing are actually an extension of that. So I discovered quite a long time ago that I really love being able to support families in supporting an older person by answering their questions, providing information, support, guidance that people are often not getting from their parents' usual doctors. And so I love doing Q&A sessions, and I also wanted to take things a little bit further. So back in 2019, I started the membership, which is an online group program in which I and professional geriatric care managers such as Michelle can provide families with ongoing guidance, direction, support, resources, and coaching. And so there are three pillars. We do weekly Q&A coaching calls. They're similar to this, except the difference is that we are actually able to unmute people one at a time and just go back and forth and talk about their situation. So that's really sort of fun and rich, a rich way to interact. So usually Michelle and I are alternating. Sometimes we have other care managers who participate as well. I also have two Helping Older Parents courses, one that focuses on memory loss, another one on, it's the first one I made. I call it the essentials with like sort of like my list of the most important things I thought people needed to know. And then we have an online members forum. It's not on Facebook. It's on a platform called Mighty Network, so that you're not bombarded by ads, and so that you can have privacy. And so in that space, Carol is our moderator. Members can support each other, get support from Carol, and also from me and Michelle in between the calls. So I'm not going to say more about it, but if you find this Q&A helpful, or if you're in the situation being on a journey with your aging parent and you're interested in this, you will get more information with the replay later on. And you'll get a few emails after that about how more about the membership and how you might join. If you don't want those emails, there's always a link at the bottom that says, I don't want to hear about this particular program anymore. And you can click that. It won't take you off the caregiver newsletter list or the Better Health While Aging list. We'll just stop telling you about the membership. Um, there's also a site, and I'll include the link in the replay. But if you want to learn more about the membership, consider joining. This is the URL for that as well. So Laju says, I would like to join. Carol has just shared a link in the chat. So thank you for that, Carol. And again, we'll send it with the replay. And with that, we're going to go now to questions and answers. So we already have a couple questions in the Q&A box. And anyone else who's here who wants to ask your question, go ahead, put it in there. And Michelle and I are going to do our best to answer. So we're going to start with the question from Jean. And Jean said, my mom has been in a memory care facility for 6 months and is thriving. However, she's been stuck on saying she can't afford her new home and it causes her anxiety. What's the best answer to give her when she asks, who's paying for this because I can't afford it? We are self-pay, but don't want her to know it. Okay, good question. Michelle, I'm going to put this one, turn this one to you because I know you end up in this situation because part of your work, working directly with families and older adults, is to sometimes be the person that the older adult is talking to in memory care, saying, "Why am I here?" or "Who is paying?" So, yeah, tell us a little bit about what you found works well.
Yeah. So first, I just want to say, Jean, congratulations on getting her moved into her new home and that she's thriving. I mean, a lot of folks like really are hesitant to make that move into memory care. And it sounds like you and your mom have navigated through that, have made it through some really big, tough changes. So congratulations to that. And then when you talk about finances with her, I think maybe I do two different things. One is I usually use some sort of fiblet that I think will work with the person. Like, oh, your insurance is paying for this, or your doctor was able to get you signed up with this program using some of the grant money that they had access to. I usually lean on some sort of fiblet because letting them know how much they're paying. I mean, first of all, right, like memory care is incredibly expensive. Where I am, memory care facilities can be anywhere from 4,000 to in excess of 10 or $12,000 a month. And for any older adult, wrapping their minds around spending that much money can just be really jarring to them. And it's something we don't really need them to worry about. So I usually use some sort of fiblet to help get them through that. And then I try to just get to a point of out of sight, out of mind. Like let's make sure they're not seeing any of the invoices. They're not seeing the lease agreement, that everything's going to you or whoever is in her life who's handling the finances, and just keep it out of sight, out of mind if possible. Um, and if you don't feel comfortable using those little fiblets to get through this with her, you can say, I'll check into it, but I think it's already been covered. And just try to say, I've sat down, I've tried to ask for a meeting with the executive director, but they've always been busy. Hopefully, I can get to the bottom of this next week, and just sort of keep kicking that can down the road, maybe, is another potential option.
Yeah. Uh, yeah, thanks for that, Michelle. And so Jean, maybe you've already come across this term fiblets. But this is something that comes up often. Since your mom is in memory care, I'm guessing she has a diagnosis of some form of dementia, such as Alzheimer's or one of the other ones. Um, and yeah, it does often become really helpful to realize that you don't always have to tell the whole truth. And that what we're really focusing on doing is helping the person feel more at ease with what's going on in their situation. And sometimes the truth is just going to cause distress. Um, and a fiblet, which is also sometimes called, a therapeutic lie, is something that's not quite true that we decide to say in the interest of, kind of their greater good. And we want to use it judiciously, obviously. We only want to use it, generally we've already have good reason to believe that the actual truth is going to cause them distress and not much benefit. And then it's like, yeah, what's the little thing that we can, fudge that will help them relax a little bit more. And money comes up a lot. This is still the generation often that has gone through the depression or remembers that, very frugal. Spending money is not their vibe. And so yeah, so just wanted to share that it's often necessary to say things that are not entirely the truth. And like Michelle, I would say congrats on getting her into this new home. It's a huge, huge achievement. Okay, let me go on to next. We had Beth, who said, my mother-in-law lives across the country. As an 89-year-old, she landed in acute care for the first time. She stated she was unable to walk, then rehab. She's now at home with personal home care. She's low income and not many assets, but too much for Medicaid in Florida. Should we be spending down or contacting an elder law attorney? Yeah, this is another one where I often turn to Michelle's expertise with this. Now, I haven't checked into them lately, but what was the name of that organization, that group, Michelle? Elder Care Resource Planning?
That's right. Hmm.
Yeah. So I do know that I haven't looked into their service recently, but a few years ago, we had been in touch with a group called Elder Care Resource Planning that sort of specialized actually in helping families do this kind of planning, including helping them apply for Medicaid if that ended up being a good option. They covered most states. So that's a potential resource to look into. But Michelle, what else might you suggest?
Yeah, and Beth, I'm sorry that you're having to help coordinate and deal with this from across the country. That, of course, makes it much more difficult. Um, so she's back at home with personal care, and it looks like you're probably trying to figure out like how do we keep paying for this personal home care, either to keep her at home or maybe eventually move her to an assisted living community. And it is true, a lot of folks end up in that middle spot that your mother-in-law's in, where they don't really have enough money to outright pay for all the care they need for as long as they might live, but they don't really have such little in income and assets that they qualify for Medicaid. One thing that's interesting, though, is that each state has its own Medicaid laws and rules. And that for a lot of states, when you're applying for long-term services and supports, either home and community-based services to keep somebody at home or um, institutional Medicaid or whatever the state may call it, their rules could be a little bit different. So, like in Georgia, we have an income cap. In Georgia, where I practice, we have an income cap for our Medicaid. It's like, I don't know if you need long-term services supports, maybe it's like $2,300 right now, which is bananas because, long-term care, either at home or in a nursing facility, could be in excess of eight, nine, $10,000 a month. So the state is essentially saying if you make more than $2,300 a month, you don't qualify for Medicaid, but there's a huge gap between 2,300 and eight or $9,000, right? So in Georgia, we have what's called a qualified income trust, where you can like funnel your income through that trust in order to then qualify for Medicaid. It's a really long way of saying that there are different rules and sometimes different regulations that apply for people getting long-term services and support through Medicaid. So I think your question, Beth, about contacting elder law attorney or the elder care resource planning that Dr. Kernisan mentioned, I think is a really great idea. Our elder law attorneys, as well as elder care resource planning, they both like help families figure out like how can we use our income and assets and leverage any of the public benefits to help pay for the care that our loved one needs. And especially Beth, if your father-in-law is still alive, the Medicaid rules for couples are even more generous than for a single individual. So you might be surprised what she might be eligible for. And one thing that I really like about the laws in Florida is that in Florida, you can use your Medicaid dollars to pay for assisted living care. Like it's not an option in Georgia, but I do really love that she could potentially be eligible for more than what you think. But an elder law attorney or elder care resource planning could be a great way to navigate through that. But I wouldn't, your question was, should we be spending down or contacting an elder law attorney? For everybody listening, before you start the spend down process, spend down is when people say, like in Georgia, our Medicaid limit is $2,000 in assets. So if you have more than $2,000 in assets, you have to spend down to that amount before you can apply for Medicaid. So a lot of people think, okay, my parents got $50,000, we're just going to spend all the way down until we hit that mark and then apply for Medicaid. But an elder law attorney or elder care resource planning might have other options for you so that you can preserve a piece of the asset that they have to be able to use it to supplement whatever Medicaid's not paying for in the future. So before you do a spend down on your own, I think it is worthwhile to consult with an elder law attorney or with elder care resource planning. And if you're looking for an elder law attorney, we do have the National Academy of Elder Law. Let's see, there's NELF and there's NALA, the National Academy of Elder Law Attorneys, and then NELF is I'm totally blanking on what their name is, but NELF is who certifies elder law attorneys to become certified elder law attorneys. I would use those two websites to look for an elder law attorney.
Yeah. Yeah, just to echo what Michelle said, experts, have consistently told me that if you're thinking you might need to go on Medicaid, it is good to get some assistance with planning the approach to it, sooner rather than later. And of course, there's a whole industry of of people, experts who help relatively wealthy people shelter a lot of assets from Medicaid, and I have mixed feelings about that. Um, although I understand why some people do it, but even for people who are, sort of in, it sounds like the space that, Beth's mother-in-law is, where, they don't have like a lot of money, but they're still not meeting the Medicaid threshold. Getting some assistance on how to work your way into Medicaid can be really, really valuable. I would recommend trying elder care resource planning. I was just looking at their website or looking for a certified Medicaid planner in that state. My rationale for that is that I know, certainly when it comes to medicine, attorneys, I always assume that attorneys are kind of going to be like physicians. They're relatively expensive. And so often your best bang for your buck is to use them for things where you really need that level of expertise. And often people who are not at quite the same level of education, but do one thing really, really well, like the nurse practitioners in Urogyn clinic, right? Or the pharmacists, we used to have pharmacists who focus on anticoagulation back when people are on warfarin. They often, I find, do a better job with that specific issue. And so I would say look for a certified Medicaid planner or try elder care resource planning, see what they tell you, and then maybe check in with an elder law attorney who's going to be a little bit more expensive and see if there's like an additional piece that you really need there. That's what I often suggest, unless people have scads and scads of money, but attorneys are relatively expensive as a way to approach this. And then, Michelle, there's also sometimes the possibility of just finding a social worker, right? But I feel like access to knowledgeable social workers seems to be a little bit plus minus.
Yeah, and the stakes are so high with navigating through the Medicaid world that sometimes the social workers, if you're on that cusp of not really like straight qualifying, and you might need some help figuring out like when to best apply and what to do with some of that money, you're probably better off meeting with a certified meeting with an elder law attorney, or like you said, a certified Medicaid planner.
Yeah. And then there's just the rest of like, what will her care look like, right?
Right.
And what's going to be the future. So we won't go into that now, but that's definitely something that we talk about a lot in the membership when this kind of situation comes up, right? Somebody who's been pretty independent on their own and then, has like a health thing and, family has to kind of mobilize both to get through the crisis moment and also to start working on what happens next. Yeah, that's something we could talk about on a future QA call. But yeah, it's great that you're able to provide support even though you're at a distance and helping her figure that out. It's a really, really important part of the puzzle, starting to identify financial options for paying for care. Okay, next, Amy said, my mother with Alzheimer's moved to assisted living after a fall and has recovered physically, but she doesn't understand that her memory loss is the reason she can't go home. Each week, our conversations about this get more contentious and it's really straining our relationship. Is there value in bringing in an outside medical resource specializing in geriatric medicine to offer an assessment, even though my mom has a doc assigned to her in the facility, more focused on physical than mental? Oh, wow. Good question. Okay, Amy. Well, yeah, I'm sorry that she's had this fall. The situation does sound really, really common, a very, very common thing. And I guess my initial thought, um, and I want to hear Michelle's thoughts on this, take on this as well, is I'm a little bit curious on like what have the conversations been like so far? And, what have is she saying, I want to go home? And what is like the response that you've been trying so far? Because this may or may not be what's happening to you. But sometimes it's fairly easy for families to get caught in this loop where they keep trying to provide like the reasonable explanation, right? The reasonable explanation is that you have memory loss and you can't go home, which may not be working. And so then, what I would say is, well, how much do we understand about how your mom sees this situation, right? So in her mind, what's going on? Is it that she doesn't agree she has any memory loss at all, right? Is it that, the more that we want to start by really understanding, like, what is the person's perception of their reality and what's going on for them? And then how can we validate their frustration about the situation being not what it is? And then what is the thing we can say so that they feel validated and heard and like we're at least in there with them on it? And the better things to say partly depend on how they see the situation and what's been, their perspective on it. Like which where do they have insight and where do they have less insight? Some people have parents who have Alzheimer's and memory loss and are actually able to acknowledge it, right? And others are in do not have insight into it, either because they're in denial or because they actually really cannot see it, cannot tell, and are forgetting it. So would an outside medical resource help? Again, it depends. What's her level of insight? What are the things that are getting in her way? And Michelle, I'll let you speak about it a little bit more, but I know that you've sort of talked about how sometimes for you, a helpful strategy has been to ally with the person you're working with in complaining about somebody else, right? Like, it's so terrible. The state says you can't go back because of, and then what's the plausible reason will depend on a little bit like what your mom's conception is, right? And what's going to sound sort of plausible. So those are my initial thoughts. But Michelle, yeah. Um,
Yeah, and one thing I would maybe encourage Amy to do too is to find out from the assisted living community how her mom is functioning when Amy's not there. Like when
mm,
you're not around Amy, like is she going to all the meals? Is she participating in activities? Is she getting any, is she if she's still getting physical therapy, occupational therapy, like is she participating in that? Like how is she functioning and kind of doing when you're not around to help give you some perspective on her mental state and how she's handling this psychologically. Because a lot of residents, what I've seen is that they will complain to their families ad nauseum, right? They just tell them how much they hate it and how everything's terrible, but they're actually kind of doing okay. Like they're coming to all the meals, they're making friends, they're talking to people, they're taking better care of themselves, they're in a safer environment. So I think the first thing I would think about doing, Amy, is like getting that perspective on how she's doing from the assisted living's perspective. And then when she's complaining to you or asking for why she can't go home, um, I think that'll help you like take it with a grain of salt. Hopefully she's adjusting really well, and hopefully she's participating, and hopefully she's just telling you a lot about how she doesn't want to be there and how it's unnecessary and unfair, which is very, very, very typical. And I think just like what Dr. Kernisan was saying is that sometimes you just can't reason with somebody who's losing the ability to be rational, right? So she is having memory and thinking problems. She just may not be able to really see it from reality's perspective because she's just losing that ability. And so maybe you can't convince her and you just have to ride this out with her. hopefully hopefully like all her means of being able to get herself back home are already gone. Like hopefully the house is already sold, or if she was renting an apartment, hopefully that apartment's already gone. Like hopefully there's not a place for her to go back to, and that's really off the table. Um, and then just like Dr. Kernisan said, like find a way that you can blame it on somebody else and tell, that person says that you can't go home until, blah, blah, blah. And then you just kind of keep waiting for that day to come, which is never going to come.
Yeah,
I would,
that's another one. Buying time, just being like, oh yeah, this is like really tough. But they said like maybe in like 2 months, next month. And then you keep like pushing that along. Actually, Amy posted a follow-up in the chat, Michelle, which is
oh, great.
in a situation like that where the mother actually is adjusting well, but insists she's miserable all the time, is there any way to salvage the relationship?
Yeah, drop the rope, right? Like it's not you. Like figure out whatever way you can that it's not you that took this away from her. So you can hire a me, right? You can hire a geriatric care manager. You can try to find a physician that will do that. Maybe like a neuropsychologist who will do neuropsych testing and diagnose her with dementia, or her neurologist. Like, is there somebody else that you can hire or take her to that can be the bad guy? And then you can be like, Mom, I'm so sorry. Like, I wish I could give this back to you, but they said that I can't, and just try to realign yourself with her. And for a little while, you might just have to back off, right? For a little while, you just might have to take care of her from a distance, like just coordinate with the staff, make sure she has everything that she needs, make sure that everything's going well, be ready to respond if she, needs to go to the doctor or needs to go to the hospital, and then just back off at some point. But we want to try, I
Yeah.
think the way that the relationship is salvageable is if you can somehow deflect and make it somebody else in the system is doing this, and that you
And
wish
and
it was different.
And also stop trying to get her to understand, because I want to highlight that what Michelle was saying is that it's not that you're going to bring in the neuropsychologist or geriatrician and that they will get her to understand,
Right.
because she is probably never going to understand
Mm-mm.
why she can't go back and agree. Now, sometimes it helps them to have somebody authoritative be like, sorry, you can't go. Um, it can help to make it seem like it's a sort of temporary thing, right? Not yet, not now, and keep kicking it down. But there's usually not going to be somebody else who gets them to understand.
That's right.
Somebody might make a recommendation,
Mm.
that they decide to follow, especially with people who aren't yet in facilities. Like sometimes when an authoritative person, like their longtime doctor, is like, I really think you should fill out that form giving your adult child permission to look at your records. Sometimes they'll agree to that, right? It's not necessarily that they're going to understand why it's necessary. They're just going to kind of take the recommendation. But letting go of the goal of, I just need to get them to understand, and then they'll stop being mad at me and they'll stop being upset about this situation. That's the part that is almost never possible, and that you have to let go of.
Yeah,
And because when families switch from trying to get them to understand to how can I empathize, validate, you know, and then as Michelle said, ideally deflect it to someone else that we can both be kind of disappointed in. That
I
tends to
agree.
help.
I agree. Just as much as you can say, just like what Carol put in the chat, like saying that you wish she could too. Be like, Mom, I know you've lost a lot in a really, really in a really short amount of time. You've lost a lot, and I really wish it was different, and I'm really sorry. And then if she starts badgering you about why did this happen? Why can't you explain this to me? Why can't, and just say like, I, I don't have anything else I can say about it. Do you want me to go? And just know that she's safe, even if you have to back off some.
Yeah.
I mean, I do occasionally have folks who don't make it through this, right? Who like say kind of stuck in this like angry period for a long time. But I would say most people do make it through this phase, and the relationships are salvageable. So eventually you won't be the bad guy. But as much as you can stop trying to convince her and just say like I know. I know. I wish it was different too.
Yeah. But she could also try mollifying her with her, like, I'll look into it.
Yeah.
Sometimes that works. And then deflecting to something that does maybe bring you closer together, like pictures, of the two of you, or something that helps her feel kind of cared for and loved,
Yeah. And then
right?
I see Catherine just put something in the chat box, and I would say that that's one thing that's really helpful too, Amy, is just like having other people who are like, I'm in the same boat. Like this sucks. Like
Hmm.
I'm doing everything I can and this is where we are. So like just having other people around you that can validate it, that you're doing the right thing, even when it hurts. It hurts them and it hurts you. You're doing the right thing.
Yeah, uh her being in the facility is often the better thing for them. So okay. Yeah, so good luck, Amy. Thank you for the question. So this is a little bit related. Michelle Anonymous asks, how do you handle the guilt that comes from setting guardrails around a parent with dementia? She isn't able to live independently, but thinks she could. Super common. She's bored and lonely and blames her kids for her situation. Um, yeah, so I'm wondering a little bit, Anonymous, what are the guardrails that you've put in that she's objecting to? But yeah, I think this has a lot of similarities with what we were just talking about uh, in Amy's situation. And I think, there's the side of how are you going to interact with her, right? And her expressions of well, how are you going to interact with her and her expressions of frustration, blaming you and her children for the situation? There's how do you manage that feeling yourself, right? The relationship with yourself. How do you take care of yourself? Seeing that you've had to do something that you didn't want to do, right? That you've had to kind of override her desire for autonomy. And and that you've, presumably put in something that she didn't want, whether that's somebody coming to the house that she doesn't want, or taking away the car, or, moving her to a facility. And by the way, it's extremely common when it comes to people with dementia that the move happens to them instead of with them at some point. And so, yes, how do you sort of manage those feelings of guilt or maybe second guessing yourself or distress that you've been part of creating a situation for her that she didn't want? And then if she's bored and lonely, is there a way to help her be less bored and lonely, right? To change her circumstances a little bit so that her quality of life is a little bit better. Those would be like the three things that I'd be thinking about. Do you want to speak, Michelle, a little bit more to the self-care aspect to it? So one thing we talked about is connecting with other people in the situation.
Yeah, and then I think giving yourself permission to take breaks or not go as often to see your loved one, like figure out other ways to check in and make sure that the care they're getting is adequate and that, find other ways to advocate for them. And then maybe if she or you have the resources, hiring, caregivers or companions to go in and help with that loneliness. Because one thing that is true, right, is that m most folks with dementia who do get angry at their loved ones, right? They get angry at their adult children or their spouse or whoever they think may have taken their autonomy and control away from them. And so sometimes you might just have to back off, take care of yourself a little bit, but in your place, maybe you could hire somebody else to go in and provide some extra companionship and just let her be mad, right? It's the disease and it's awful. It's really, really awful. Um, but connecting with other people to know that it's not your fault and that, you're not the enemy. The dementia is the enemy, right? That's one thing that we often tell people is that you're not the enemy. You're not the bad guy in the situation. The dementia is the bad guy. So just keeping that in focus, that you're dealing with the cards you've been dealt, and that's the best you can do. But it is really hard. It's really, really hard.
Yeah, that's really hard. I mean, I would say, part of what I've seen over the years, and especially, running the membership these past several years, that it's an ongoing process managing guilty feelings that come up, but often realizing that you were presented with a bad situation where all the options were bad, and that often imposing those guardrails, as much as they don't like it, was kind of a reasonable choice and often the best of a series of bad possibilities. Realizing that it's not your job to get, for them to be happy, that's trying to strive for them to be happy or to get all the right outcomes or all the things that the geriatrician recommended, happening, is it's not on you to make that happen. It's often not possible. And that really your job is to sort of like accompany them on this journey as best you can to show up, and offer possibilities, which they may take on or which may work out or not work out depending on like the rest of the system. And that it is hard. They're often not going to be entirely happy. And it's hard, and that's just kind of the way the journey goes. And that it does help to get support from other people, helping a parent. And then, our role is to be there. We've seen like a lot of this is to provide some guidance on, here are some things you can try. They may or may not work. Here are things that almost never work. Don't expend your energy there. And, remind you and give permission to take some time off, leave them on their own a little bit more. Like who else could step in? So yeah, those are some of the approaches that we've seen be helpful to families we've worked with. But yeah, it's really tough. Very, very tough. Okay. Julia said, my husband, 84, is struggling with grief and trauma as his twin brother took his life last year. Oh, I'm so sorry. That is really tragic. His doctor has just prescribed quetiapine and he's already taking mirtazapine. We're not sure if this is going to be helpful. We're keen to hear your thoughts. Wow. Well, I guess my question would be, it sounds like you said last year, so it sounds like it's maybe been already a year. And um, my initial thoughts are what kind of support has been tried, especially in terms of, therapy. I mean, medication can be helpful, but what kind of therapy and supports has been offered to your spouse? And then is it that he's declining it, right? And that, what we need to do is brainstorm some ways to support him in giving some of these therapies and options a chance? Or is it that they've actually been tried and they are not working? Medication by itself, I mean, quetiapine, that's brand name Seroquel, 25 is not a very, it's not a very high dose. It's an antipsychotic. I'm sort of wondering, is that because he has been having some psychosis symptoms? Is that to help with sleep? Uh, does your spouse have a diagnosis of dementia, Alzheimer's, or a memory cognitive problem and is getting agitated and they're trying to manage it that way? So Julia said he had 6 sessions of bereavement counseling, but I don't think it was deep enough. Yeah, you know, 6 is better than nothing, but it's not a lot. Michelle, do you want to share some thoughts? I know you've done psychotherapy for older adults at times as part of your work.
Yeah, 'cause, and there are quite a few options that he might be able to tap in, especially he might be able to tap into, especially if he can join a Zoom session or engage in telehealth. Um, Julia also just added his memory has been impaired by the trauma we feel.
Hmm.
So I like the direction you're going in, Dr. Kernisan, talking about like the other therapies, because we know that when people are dealing with depression, anxiety, grief, trauma, that the medication helps, but the thing that's most effective is when we pair together like some form of psychotherapy support with the medication. So there are a number of psychotherapists who do take Medicare or Medicare Advantage plans or who are private pay, that could offer that specialized psychotherapy to help him, get deeper than what the bereavement counseling provided him with. So I think it would be worthwhile to look at, is it Psychology Today has a really great searchable feature to figure out like
Hmm.
who's in your area, who's doing
Hmm.
in-person sessions or virtual sessions. There's also a lot of great suicide survivor groups online. You might also have some that meet in person in your area, but I think being able to meet with other survivors who've lost people to suicide can be really, really helpful. The other thing that I'm curious about, I mean, it sounds like his symptoms right now and his suffering are pretty severe. I wonder if he would meet the criteria for a partial hospitalization program. So a lot of
Mm.
behavioral health centers do offer what they call a partial hospitalization program, where you go from like 10 o'clock in the morning to 2 o'clock in the afternoon, and you get group therapy, you meet with a psychiatrist. It can just be a really effective way to work through some of these intense moments of suffering. And usually the insurance pays for it. So I would also be curious if, a partial hospitalization program might be appropriate for him. Um, and yeah, it sounds like he could use a little bit more support getting through this.
Yeah.
And what
I
you said,
mean,
and also
uh,
what you said about his memory being impaired, if he is dealing with any depression, depression is one of the great dementia mimickers, right? So a lot of people who are dealing with depression, some of their symptoms can look a lot like dementia.
yeah. And it can be quite hard to tease apart. Julia said we're in the UK and I haven't heard of partial hospitalization.
Mm.
Yeah, I'm not sure what's available there. I will say at age 84, so depression can be a dementia mimic. Some people were already kind of slipping a bit, and this has accelerated it. But you know, in general, often what helps people is sort of nourishing social contact. So time with people whose social presence they find nourishing and supportive. Um, Therapy also. And then sometimes help and support in getting into activities or spaces that are restorative for them. So there are some people who really enjoy being outside, but maybe when they're feeling a lot of grief and trauma and difficulty, they're having difficulty getting themselves out. And so a little bit of support into getting into those places because they can't quite do it on their own. I think of those things, but medication alone tends to be not adequate. So I think you're right to be thinking, what else can we do? And that he might need more, and I hope you find it for him. And someone had asked, is mirtazapine, which was just mentioned, a medication that can be given for weight gain for the elderly and also for mood regulation? And what does a psychotropic medication mean in the wider context of geriatrics and management? Yeah, mirtazapine, the brand name is Remeron. It is an antidepressant. It does also increase appetite, so sometimes given for that, especially if somebody has depressed mood and isn't eating very much. It can also make people a little sleepier at a certain dose. So sometimes if they've been having a little bit of trouble falling asleep. And then psychotropics. Earlier, I said that the quetiapine, Seroquel, is an antipsychotic, but psychotropics are anything that affect people's brain chemistry and brain function, right? So, antidepressants, anti-anxiety medications, those are all psychotropic, um, and yeah, we think about them in geriatrics. They sometimes often the side effects are more significant as people get older. So, good question. Okay, Annalise said, my dad has trouble with impaction. I think she's referring to fecal impaction. When he was with me 4 years, he had to go to the emergency room 3 times until I finally started giving him Metamucil, Miralax, and prunes. He would have 3 big BMs every day and no impaction. He's been in memory care a year now, and I know he does not have those big BMs. They give him the Miralax, but when they give him the Metamucil, they don't give him enough water. They say he refuses it, so they don't give it to him. Also, they say he refuses the prunes. How can I make sure he's not headed for another impaction? Good question. Yeah, so I think I saw that Carol already shared my article on constipation. And yes, when people, constipation is usually defined as like having to strain to have, you know, a bowel movement and not having them very often. The goal is to have a comfortable one every 1 to 2 days. Probably every day is a little bit better. And people do tend to get constipated easily as they get older. And so daily or regular laxatives helps keep things moving because if things get too slow, then you get an impaction where it's so hard and blocked up down in the rectum that, as Annalie was saying, some people have to go to the emergency room where they have to have enemas and have it kind of manually dug out. And those are, that's really hard on an older person. So, good for you, Annalie, for first of all continuing to pay attention to his bowel movement habits and monitoring that, because it's definitely better to sort of be proactive about it and try to increase the laxatives and intervene before somebody has a significant impaction. It's true that in geriatrics, we're often a little plus minus on Metamucil, which is a fiber supplement, because you do have to drink a lot of water with it. Otherwise, it kind of congeals and turns into like cement in there. So, um, what you can do is, first of all, if he still is, I guess my question is he still having a bowel movement every day, right? If he's having a reasonably comfortable one every day, even though he's not having the three, I would say you're probably okay. Um, if he's refusing the prunes, would he drink prune juice? Another option, prunes are in some ways, they have some overlap with Miralax. They work as an osmotic laxative, meaning they draw liquid water into the bowel to make the stool softer. I don't know if you've ever had him try something like Senna, which is a little bit of a stimulant. That could help too. So I just think, could they tinker with some things that aren't the Metamucil to help him have at least like one, a comfortable bowel movement every 1 to 2 days? If you're worried that he might be heading for an impaction, generally when people, older adults, are getting chronically constipated, if you get an X-ray of their belly, which is usually fairly straightforward to do, it will show if there's a lot of stool in the colon. The colon loops will be distended, and sometimes the radiology read is, well, informally, what they would write in the chart is FOS, full of stool. And that's kind of a sign that things are not moving along and that the person is at, more risk for an impaction. So that would be another thing that you could potentially do. He also wrote, I used to give him strong coffee. They only serve decaf. Uh, have you heard of that before, Michelle? Like facilities that don't give caffeinated coffee? Really?
Yeah, I think it's pretty common, especially in memory care.
Oh, I see. Okay. Well, um, yeah, well, I don't know if he could take a caffeine tablet. Caffeine does come in tablets. If you think that really helps him as a stimulant, but maybe trying the Senna as a stimulant. So those would be my suggestions for that. And anything you want to add, Michelle?
Yeah, I'm curious what you think if well, Annalie, I'm wondering if you have a prescriber on your side who's taking this seriously and helping you out. It can sometimes be so frustrating to get the physicians to pay attention to this potential constipation impaction issue. Ugh, sorry. But
Mm-hmm.
one good ally that I have found over the years is to get palliative care involved. I don't know if he would have any other diagnosis or anything that would make him eligible for palliative care, but I feel like it could be an option. And I feel like our palliative care nurse practitioners and hospice nurse practitioners are sometimes the best at dealing with constipation and impaction issues. And then having them on your team might also help you to avoid a future ER visit because the nurse practitioner might be able to come make a house call visit to him there and might be able to help with any impaction if he were to have it. So I would also think maybe about just seeing it. I mean, it doesn't hurt to see if he could qualify and add palliative care to his team. And then in terms of the coffee issue, I mean, maybe just talking to the executive director or the memory care director about, do we have any options? Like, can I buy a Keurig machine and make sure that we have enough like little coffee pod so that he could get his coffee from this machine and give him a good strong coffee out of the Keurig, even if as a policy they don't have decaf for everybody.
Mm-hmm. Yeah, that's a good way to be creative. Um, and yeah, just briefly to follow up on palliative care, I think it's a great idea to look into it. Palliative care is a discipline, a branch of medicine, and hospice is a particular program and services within palliative care. And people sometimes, ask me what is the difference between the two. So palliative care is a lot of services that attend to symptoms and comfort or prognosis potentially. And you don't have to be on hospice to get it. What I found is that the availability of palliative care in the outpatient setting is kind of variable.
Right.
So it's worth like looking to find out. You can talk to the insurer, you can talk to his healthcare system. Sometimes hospice companies have some of it available because they kind of use it as a pre-hospice um, uh, service. And there's a website, I think it's called getpalliativecare.org, that might be able to help you access it. Whereas hospice is, a defined Medicare benefit. There are lots of hospice agencies set up to deliver it. Yeah, I always encourage people to look and see, but I found that it's much more variable what's available for outpatient palliative care. But you never know. So I think it's a great idea. Thanks for bringing it up, Michelle. Um, okay. Susan said, my 83-year-old dad was diagnosed with AML last year. Prior to that, he started showing signs of cognitive decline and had nurses and other non-primary docs express their concern he's suffering from early dementia to me. After a year of chemo, I can't tell anymore what his chemo brain or the decline he had prior to the diagnosis. My question is, his PCP team never addresses these issues despite me raising concerns. Questions are always directed to my dad, and the info he provides are misleading and not accurate of his current reality. So his care team dismisses me. How
Mhm.
to communicate, how to effectively communicate reality, instability, confusion, not eating, weakness, etc. I've tried posing my questions and offering info right away in the appointment. His docs keep saying my dad understands the situation and treatment plan, but as his caregiver, I know he doesn't. His insight and judgment are lacking. It's concerning to me that he doesn't seem to be tolerating treatment well. Ooh, wow, what a situation. Good question, Susan. Okay, well, yeah. So whether it's chemo brain or some pre-existing neurodegenerative condition, um, I think it's a legitimate question whether right now, in this moment or these days, um, what are his cognitive capacities, right? How well does he understand things? How well is he able to attend to things he needs to attend to, whether that is his self-care at home, whether that is making decisions about his life where he lives, whether that is making decisions about his treatment. Um, and and so I guess what I wonder about is like what's the basis for his doctor saying he understands the treatment plan? Like have they actually asked him questions to check and make sure that he has capacity to understand them? So I wonder if you've been present when they talk about that. Um, and then in terms of effectively communicating reality, I mean, they do have to be willing to hear you. So I sort of wonder, I have a um I have my book actually, When Your Aging Parents Need Help. And there's a cheat sheet in there of 21 cognitive signs. Um and I sort of wonder if you were to um look through that, like how many of those is he showing? And also how many of his activities of daily living, or especially what we call instrumental activities of daily living. So the daily life tasks that we learn to do as teenagers, things like managing your finances, grocery shopping, managing your communications. Okay, so you have the book, right? So if you get that cheat sheet, the cheat sheet for ADLs, activities of daily living, instrumental activities of daily living, and cognitive science, but actually like documenting like this is what he's having trouble with, right? Um, because if you bring that to him, like here's what we see him having difficulty with, like actual specific observations, and say, we're concerned that he's actually cognitively impaired. Um, and then I'm sort of wondering, like, what do you want them to do differently, right? Is it that you're concerned that he is making um, decisions that are actually harmful to him or not quite right, regarding his treatments, right? I sort of wonder, like, what do you wish that they would do differently if they realized he was as impaired as you think he is? Are you, is it that then he might, be incapacitated and you could take action as power of attorney, right? Because sometimes there's a power of attorney, form that only becomes active if the person is incapacitated. Is it just that you want to make sure they also loop you in and so that you know what the treatment plan is? Is it that he's pursuing treatment that you think is actually not in his best interests? And if he were cognitively intact, he wouldn't be choosing it. Um, yeah, I sort of think about that. Is it that he's choosing to live alone in a situation that you think is increasingly unsafe? Um, and if the doctors or somebody would agree with you, he's impaired, you would have better options for bringing in some care and support that you think he really needs. Um, yeah. I also think about asking them, like, how do they see his cognitive state, right? Um, is there something specific you can ask them to do, like a MOCA, especially if you have also evidence that he's having trouble with instrumental activities of daily living, and some of those other cognitive signs? So Susan wrote, I wish they'd take the time to understand my concerns and at least validate. You're present at all appointments. You just want some support as you feel alone. Oh, yeah. Well, yeah, no, it is like frustrating that they're not taking this in and validating it. And um,
Is this also a good time to like think about a palliative care? I don't mean like
yeah, yeah,
palliative care for
potentially.
everybody, but
I
someone,
mean, they pay more attention.
right?
Yeah, yeah, yeah. And you actually should be able to. So palliative care usually is available to people who are getting treated for cancer. It's generally available in the hospital as an inpatient consult and often available as part of cancer treatment. So I love that idea. That's another possibility, Michelle. And and I guess in terms of like why they're not addressing it, some things that come up. His cancer. So a lot of providers, I think, are a little bit alarmed by the possibility that somebody might be impaired and they might have to do something about it, right? They're not sure how to particularly assess it. It's like a can of worms that they don't want to get into. They are usually practicing under a fairly high pressure situation where they don't have a lot of time. They already have too many things that they're trying to get to in the time available. And when families bring up, and I think they might have this memory problem and all this stuff, it's like, oh my God. Um, which is part of why it can be helpful to have an idea of like what's a really specific thing you want them to do, right? Is it to do a MOCA? Is it, a referral maybe to a neurologist, who might be able to focus just on that, right? His cognition, or a geropsychologist or something like that. Um, those would be some of the things I'm thinking. And then yeah, for support, again, caregiver support groups, or the membership, right? That's part of what the membership um, is about. Laju asks, is there a way to get a medical advocate when these concerns are dismissed? Are there advocates in health insurance coverage or only independently hired? Your insurer is probably not going to provide that kind of service. I know there are some people who offer services as like patient advocates. Do you know much about that, Michelle?
The other thing I'm thinking about too is that a lot of cancer clinics have social workers that are often underutilized. So I wonder if his cancer clinic has a social worker that you might be able to sit down with. Because I guess one of the things I'm reading in Susan's question and the follow-up information is that she just wants a partner to help her sort through all of this.
Mm-hmm.
I remember having an 83-year-old client he didn't have AML, but he had another like blood
And
cancer.
AML is a form of leukemia, everybody.
And he had a different kind of blood cancer and everybody and like okay, he was more advanced in his dementia. He was living in a memory care facility, didn't recognize his wife, like didn't know what was going on, and everybody was just happy to keep treating him every other week, just come into the infusion center. And I was the only one who was like, "What are we doing? What are we doing? Is this what he would want?" Like, and it was so hard and so lonely to get and scary to like try to get the providers to talk about this. And they're like, "Well, we can treat it, so we should." And I'm like, "But what for? Like, what are we doing here?" Is this not how he wants to spend 3 or 4 hours every other week sitting in this infusion center? He's getting agitated. Anyways, so Susan, I totally feel you. It feels so lonely and scary to not have somebody to sit down and go through that with. I finally like eventually my guy's family stepped in and like advocated and talked to the primary care doctor and just were like, we're ready to stop. Like he's too agitated. What are we doing here? And we switched him over to hospice. Um, but it was yeah. It was
Yeah.
really hard to get them to have those goals of care conversation. Um, and I'm sorry. I
Hmm.
wish it was different.
Yeah. Yeah. And I would say it's important to, um, I think it's great that you're recognizing this need for support. A lot of people try to tough this out on their own,
Right.
and I think it's a shame. But yeah, there are actually like Reddit communities for people supporting aging parents that are quite active. Those are free. There are, locally support groups. Um, you know, this is part of what we do in the membership, right? Is we provide that kind of like support, the members supporting each other, plus me and Michelle. Or you can potentially look for an aging life care professional like Michelle, right? Who will be your like side by side partner and even like getting in there, potentially going to appointments, and helping out, right? That's like really, really valuable as well. But yeah, just realizing that if you're feeling lonely, find support. And there are different ways to find it at kind of like various price points. But there's no need to do it entirely on your own because there are, especially with the internet, there's the option to connect with other people in similar situations and get some of that support. And it's important. It really is. So thanks for the question and good luck.
Yeah.
Um, Okay. Leanne said, my 85-year-old diabetic mom refuses to eat anything other than sweet foods like biscuits and fruit bread. She's losing weight, looking very frail. I've tried providing a variety of foods she used to like, but she says I'm not hungry or I don't like that. All right. Well, so I guess, Leanne, for something like this, I think about a couple things. I mean, she's losing weight and looking frail. And so I think about, well, where is she at medically, right? Is that something that um, unintentional weight loss should ideally be medically evaluated to figure out what's going on and how we can turn it around. I don't know if she's having memory or thinking problems, right? Those can contribute to, first of all, people being kind of less rational and reasonable about their food choices, right? And they can be like more disinhibited about just pursuing their impulses and urges. They can be forgetting to eat more nutritious things. It can be associated with frailty. Um, could she have something else going on medically, right? That is causing her to lose weight. And then in terms of how much to push against what they want to eat, um, I think we need to balance quality of life against other objectives, right? And so she's 85, she's lost weight, she's frail. If medically she seems to be kind of declining, and maybe we're going to figure out, maybe not, one approach would be, and especially if she's cognitively impaired and is not going to understand why she can't eat the things that she'd rather eat, it can be reasonable to say, well, let's focus on her quality of life and enjoyment for whatever time is left, and support her in eating more of these things that she's enjoying, right? Um, so we can push back and try to do what's healthier for her, but we should first of all have a sense of realistically how likely are we to be successful in one, does she want her life extended, right? Two, how likely is it to be successful? Three, how important is it to her right now, extending her life versus other considerations? Um, because sometimes even if the person, is amenable to their life being extended, it might, if we look into things medically, it might seem like we're kind of unlikely to turn this around, right? And so then, okay, biscuits, fruit bread, enjoy, what time is left. What else can we do for her to help her enjoy this time? Right now, are there people she wants to spend time with? Are there places she'd like to go? A few last things. Um, so so yeah, for situations like this, I always try to get a sense of like what's the underlying medical situation and what are our options? What are this person's preferences? What's important to this person right now? Do we have any indication of what they said in the past, right? If they were kind of frail and unwell, what would they want to prioritize? Would they want to, take every last chance to try to get better and live longer? Or would they want a switch to, being comfortable and enjoying themselves for their last months or however time there might be left? Palliative care again could be really helpful here. So we're 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 coming back from that. The doctor said she's 2 points off having memory investigation. 2 points of what? The point scales, that's just like part of the how we determine whether somebody's having memory difficulties, right? It's sort of, again, I sort of mentioned my book and the list of 21, cognitive signs. I also have a video about it that you can look, but how many of those sort of symptoms or difficulties is she having, and what else is she having difficulty with, right? Does she seem to be having trouble remembering things? Is she having trouble doing things she used to be able to do for herself? I would think about those things. And so I don't know if you said in the chat, Leanne, because now I'm trying to look. Has she been evaluated for the weight loss? I would definitely recommend that. Okay, thank you for the question. And Nicole said, um, what suggestions do you have for me as my 82? And I'm mindful of the time too. Thank you, Michelle and Carol, for still being here. I think we'll go about like another 10 minutes or so. Is that okay?
Sounds great.
All right. So Nicole said, as my 82-year-old mother's main hands-on caregiver, when she shrugged off her falls and avoids sometimes, a lot of times, she refuses to wear her life alert while in her home and out and about. She's a major fall risk. She's had 5 hard falls, resulting in multiple trips to the ER in the past 5 to 6 months. All right. Well, I'll give you some of the things I think about, and then I want to invite Michelle to comment on this because I know Michelle. I imagine you've had clients who are kind of like this as well,
I'm thinking
right?
about my own mom who keeps falling and won't wear her alert button or use her walker. So
Yeah, yeah, there you go. Yeah, yeah. Our families are the worst. They really don't listen to us. Um, so yeah, so my initial thought always when I hear that an older person isn't doing the things that their children or family think they should do is, one, are we dealing with cognitive impairment, right? Like memory or um, thinking problems? Um, if we're not sure, maybe we need more evaluation because if we are, we're going to have to take a slightly different approach to our options. I mean, older adults get to make choices that are bad for their health and scare their family um, if they are otherwise like cognitively okay enough. They can decide to take all these risks. So are we dealing with somebody who's making choices that are alarming to us and that we don't like, or are we dealing with somebody who's impaired and also can't quite see how much risk they're putting themselves in and the potential consequences? Um, what's most important to her right now? Is there something that's important to her that we could kind of leverage as a way to get her to do something? What's been done for evaluating her for falls, right, so far? What do we know about her falls? What's been proposed as a way to reduce those falls? Um, has she been checked for osteoporosis, and have we sort of taken some steps to see if we could reduce the the likelihood of injury if she does fall? Those would be some of the spots where I would start. And let's see. Maybe I'll turn it to you, Michelle, while I look and see. Michelle's actually, sorry, Nicole said she laughed about almost burning the house down because she thought the smoke alarm was a car alarm outside. You're filled with constant worry. She doesn't see the consequences of her actions, and you have her in fall prevention. I mean, first of all, it sounds potentially impaired. You don't say whether she's been evaluated for that or not. And then I'm a little curious what it means to be in fall prevention. But Michelle, maybe you can talk about especially what do you do, especially with those older adults who are having some memory or thinking issues?
Right. So, I mean, it sounds to me that, there's so many red flags here about her being able to live at home alone that I wonder if we start thinking about like the bigger picture, like how do we get her to stop living at home? Living, is she actually, can you say in the chat, Nicole, um if she's at home alone or if she's at home with an adult child maybe? So it sounds like there's a sister, sounds like there's Nicole
She
and her
also
sister that
mentions
are
SF
helping.
Unlock. Unlock is great. It's a PACE program of all-inclusive care for the elderly here in San Francisco, actually. Is she in Unlock?
Oh, so maybe she's doing like the adult day there every day. Okay. And Nicole, does she live with you or do you live with her? No. Okay, so she lives alone. And it sounds like maybe during the day she has access to the Unlock PACE program. But it does sound like, I mean, one of one of my red flags, right, when I'm like, all right, this is not working at home anymore, is when a person can no longer figure out what to do in case of an emergency. So if she thought the smoke alarm was a car alarm and didn't realize that she'd burned a pot of beans, it sounds to me like there's a bigger conversation that needs to be had about how do we keep her in a situation where she has 24/7 supervision. Right, that this is not just about fall prevention, but it's about like her overall safety because she no longer has the awareness or the ability to take care of herself and to keep herself safe. Um, yeah, and it sounds like one of the things Nicole said is I'm filled with constant worry. So I think and then I guess we have to start thinking about like what are some of her options for living in a situation where she has 24/7 supervision. And it might be a situation like what Dr. Kernisan talked about earlier, where this is going to happen to her, not really with her, right? That she's probably not going to be on board with any major change like that, but that it may be something that just has to be done, but that um, not addressing it is at some point becomes neglectful on your side and your sister's side, Nicole, right? Like once we know that she can no longer, um, once we know that she can no longer care for herself.
Yeah. Well, I want to say this and for this particular situation, is interesting because it sounds like Nicole's mother is in a PACE program. Um, and so I want to speak really quickly about that. PACE is Program of All-Inclusive Care for the Elderly. It's a special model of care for frail older adults who are otherwise nursing home eligible. And Unlock in San Francisco was the original version of PACE. I don't know if you knew that, Michelle.
Oh, that's really cool.
Um, and so this is a special program that combines sort of an adult day health center with a whole kind of medical team that is often led by a geriatrician or by someone who has otherwise had some training in geriatric care. So you have to use your Medicare money and Medicaid money together. So usually people who are in PACE programs are eligible for Medicaid. If not, they can just pay the difference. That does tend to be a few $1,000s a month. But then the PACE program provides all medical care. So they become your primary care provider. They also pay for your specialty care, pay for your hospitalization, all of it. And people who are in PACE programs usually get transportation to the PACE center. Some of them come 5 days a week, some of them only go a few days a week. And at the center, there's like a day program, but also the doctors and nurses are there. Physical therapy is there. There is a pharmacist there. And so this whole interdisciplinary medical team is there to also provide care. So, how does one join a PACE program? If you look up Medicare PACE, you'll find the Medicare pages about it, and then there are directories of it. It's available in many states, and then you have to find one that is near you. So, um, when people join PACE, they have to be able to live at home. So they're nursing home eligible, but they have to be able to live at home. And usually they're able to live at home because there is a family member providing some additional support, or maybe there's like a paid caregiver or something like that. But normally when people join PACE programs, when they then decline to the point that they need a facility, the PACE program will place them, right?
Wow, that's cool.
Yeah. So just for Nicole's particular situation, I, you know, the PACE Center has a social worker, right? They have an interdisciplinary team who is presumably aware. of this. Uh, okay, so what you're saying is you have to switch to inclusive Onlock. All right, so it sounds like maybe she went to a fall prevention program that was being offered by Onlock, but she's not actually
Oh,
enrolled in
okay.
PACE.
I see.
Um, and she's close to the 30th Street PACE. Yes. So, wow, she's right here in San Francisco. Yes. So you could look into whether she would be eligible to join PACE, because otherwise, I was going to say if she's in the program, they would be on top of this, right? You just need to make sure they know she's having all these falls at home. Um, and yeah, PACE is great because you do get this really comprehensive interdisciplinary care that is very good for older adults who are frail, who are having memory issues, who have complicated health things. Um, the issue is that usually people either have to already be on Medicare and Medicaid. Well, all older adults essentially are on Medicare, but they have to already be on Medicaid, or they have to pay the difference, which is a few $1,000s. And at that cost, people sometimes feel like they would rather invest in assisted living, even though assisted living is often not as much assistance as people think it will be, which is another thing we can talk about at a future call. But yes, you could definitely look into PACE and paying for that. So I do see we have a few other questions, but I think I'm going to wrap this up. Really briefly, Jose had said, what will become of elder care given the shortage of caregivers? That is, a billion trillion dollar question. Really to be determined. He had also said, what about using humanoid robots in the near future? I don't know that that's going to work out in the near future. Maybe eventually. Like we'll have to see when Michelle and I are old and frail, who's taking care of us. Um, although we both have children, that's like, often like your best long-term care is a daughter or daughter-in-law. Next nephews, nieces, anyone in the younger generation. But maybe it'll be robots. I'm not sure. But yeah, it's definitely an important policy question. And then just to speak to someone who popped in a question at the end, how do I deal with dementia, violence, and no recall of the events? My husband of 93 has recently become very aggressive, does not understand his own behavior. Um, I would definitely let the providers know. Um, we're not fans in geriatrics of antipsychotics and medication, but when people with dementia are actually hurting their caregivers, that's when, it can entirely become justifiable to think about medication. There is an article on Better Health While Aging about dementia behaviors. There's two of them. One that kind of goes into how you sort of troubleshoot like what might be triggering it, and working around it. And the other one covers the medications in depth. And so I would suggest that, but I'm sorry you're in that situation. It's very difficult. So, with that, thank you so much for coming. I'm going to wrap this up, but we'll probably do another one in January. In the meantime, if you would like to support the work that I am doing with all the free resources, some options. If you're on this journey, caring for an aging parent or another older loved one, we would love for you to give the HOP membership a try. People who join have 30 days to decide whether it's a good fit. If not, they can request a refund and come out. You can also subscribe and share. So join the Better Health While Aging email list if you're not already on it. Most of you probably are. And then I do have two YouTube channels. I have a newer one that is specifically about elder care called Helping Older Parents. And then I have the one I started a few years ago for Better Health While Aging that especially covers aging health kinds of topics. You can even become a supporting member of the Better Health While Aging YouTube channel at $3 or $5 or $10 a month. But regardless, I plan to keep doing this because this work is important to me. So thank you for being here today. And especially thank you for all you're doing to care for an older person in your life. We geriatricians and, And Michelle, all of us who professionally work with older adults cannot do what we do without collaborating with families. So your role is super important. We're super grateful for you and happy to be part of your journey in whatever way we can be. So happy rest of December for everybody. And hopefully we'll see you again on another upcoming call. And huge thank you to Michelle for being here with me. I always learn so much from her, and to Carol for manning the chat as well. So take care, everyone. Have a good rest of your year and a good rest of your day.